Alaikum wa rahmatullah. I'd like first to thank you all for attending the conference, and I'd like to thank Dr. Hassanein for the kind invitation. So I'm going to present one of the studies that has been recently published in the Journal of Diabetes and Clinical Endocrine Practice, and it's about the impact of albuminuria and renal function on Ramadan fasting. And before I start, I'd like just to take a moment to discuss something with you. I guess we all know that diabetic kidney disease, when we divide it into, especially in the risk calculator, into moderate and severe. And those with mild disease, those are the ones with normal eGFR, but have albuminuria. And they are not included in the risk calculator. Now, my question to all of you, if you had a patient with albumin excretion of 600 or 900, and he attended your clinic and he has normal eGFR, would you advise him to fast or not? So my question in another way, do you think microalbuminuria is a risk in fasting patients? Who would say yes? Normal eGFR, albuminuria with normal eGFR. Okay, so now we try to answer this question in this study. And you know, as I told you, microalbuminuria per se, when we talk about a patient with type 2 diabetes, we talk about microalbuminuria is a predictor of cardiovascular disease. And it is not a direct cause. So we predict cardiovascular disease when there is albuminuria because it indicates glomerular injury. And in Ramadan, we probably face a lot of issues in patients with diabetic kidney disease. I think the first one is alterations in glycemic control. The second will be probably dehydration during Ramadan, hypoglycemia, hyperglycemia, and deterioration in kidney function. And that's why all the studies done in Ramadan actually falls in two categories. The first category, we look at the impact of fasting on the comorbidity or the chronic kidney disease. And the other form of studies is we look at the impact of chronic kidney disease on fasting outcomes. So what we did here is we tried to look at the impact of chronic kidney disease on fasting and fasting outcomes. So this was basically a retrospective study, part of the DAR Global Survey that was done in 2020 to 2022. We recruited almost 13,000 patients. And the participants were from different areas in the region. It includes Middle East, Gulf, Turkey, UK, Africa, Indian subcontinent, so a variety of patients. What we did is we divided those patients into 4 groups. Those 13,000 divided into 4 groups. The first group, people with normal kidney function. And the rest are diabetic kidney disease. Some of them just microalbuminuria with normal eGFR or low eGFR with no albuminuria. So non-albuminuric diabetic kidney disease. And the third group is the group with reduced eGFR and albuminuria at the same time. And we tried to look at a couple of outcomes, the hypoglycemia, the hyperglycemia, rates of fasting interruption, and the severe episodes requiring medical attention. So these are the baseline characteristics. I think we all agree, and I don't need to go through it, patients with diabetic kidney disease are older, has longer duration of diabetes, and probably has as well longer duration of diabetes, and they had a higher systolic blood pressure and a higher diastolic blood pressure. So it's quite obvious and quite well expected. When we look at medications used, the more advanced the disease, the more patients are using insulin, and that is expected because we drop metformin and we reduce the dose of many other medications, and we have to reduce insulin. So it is expected that the more advanced case, they're using more insulin, while metformin use drops as the EGFR drops down. Unfortunately, the use of SGLT2 inhibitors is not that significant. We have only those with albuminuria alone, only 16.9% are using SGLT2 inhibitors. So this is with regard to medications used by subgroups. Now, again, if we look at complications, again, if you look at the graphs, they're quite similar. No diabetic kidney disease, low number, and as you go to the later stages of diabetic kidney disease, they will have more hypertension, more dyslipidemia, more retinopathy, more neuropathy. I tried to do it in a heat map way where if you look at no diabetic kidney disease, it's the percentage of patients is very low, we're in green, and as you go to more advanced, the complications, whether hypertension, hyperlipidemia, retinopathy, or neuropathy, are more prevalent in this group of patients. Now, when we come to the results, if you look at participants with diabetic kidney disease, actually those with microalbuminuria alone, without being asked, 50% of them has increased the frequency of self-monitoring of blood glucose. Around 29% has remained on the same pre-Ramadan frequency. However, around 20 to 25% did not monitor at all. If we look at Ramadan-focused education, around 58% of those without diabetic kidney disease received education, and 77% of those with microalbuminuria has received education, but still, 1/3 of them still lack targeted guidance before Ramadan. When we come to the days fasted during Ramadan, if the graph basically shows you that though whether they're high risk or not high risk, most of them intend to fast during Ramadan. And most of them fast around 27 days. So in summary, during Ramadan, around 27% of them, 76% with low EGFR has fasted during Ramadan. And even some of them has continued to fast in Shawwal. So what about the hypo and hyperglycemia? I want you to focus only on those with microalbuminuria, because I think we all agree that advanced kidney disease are high risk. What about those with microalbuminuria alone? If you look at fasting during Ramadan, the percentage of people fasting during Ramadan was high. The hypoglycemia, daytime hypoglycemia, was significantly higher than other groups. If we look at hyperglycemia, around 24% of those with albuminuria alone had hyperglycemia. And I want you to compare them, because until today, we were comparing them to normal kidney disease. Just compare the first and second graph. Hyperglycemia is higher, hypoglycemia is higher, even, and it is not in this graph, severe hypoglycemia or hyperglycemia requiring hospital admission was higher in patients with albuminuria alone. And this is just sort of an easier way to look at the graph. 25% had daytime hypoglycemia in the diabetic kidney disease group with albuminuria and EGFR. 4.5% had severe hypoglycemia in diabetic kidney disease with albuminuria and low EGFR. 24% of those with albuminuria alone had hyperglycemia, and some of them required hospital admission. Almost 20% had to break their fast during Ramadan because of hypoglycemia. So these are significant numbers we were not aware of previously in those with albuminuria alone. So if we look at the impact of albuminuria in kidney function, if you look albuminuria, even if the eGFR is normal, is associated with an increased risk of hypoglycemia and hyperglycemia during fasting that reflects early renal injury and metabolic instability. Reduced eGFR, and we are aware that because of a very low eGFR, there will be retention or retention of insulin, and they are likely to develop hypoglycemia. So the hypoglycemia is seen more in those with low eGFR and albuminuria together. So until now, as I said, we don't consider albuminuria as a risk factor, but I think in the future we have to run a couple of studies to know whether it's actually a risk for fasting or not. So this is exactly what I mentioned, that albuminuria signaled reduced physiological resilience and greater glycemic instability, even with preserved eGFR. And it is associated with higher rates of fasting breaks, hypoglycemia, and hyperglycemia. So what would be the recommendations after this? And I think all my previous colleagues has actually mentioned this, because this is an important step for safe fasting in Ramadan. We have to do pre-Ramadan assessment. What we have to do now is to look for albuminuria as a risk factor, give those with albuminuria alone education and focused education, because they are likely to have more hypoglycemia and more hyperglycemia. We have to teach them and educate them on self-monitoring of blood glucose, and we have to do medications adjustment. So what were the limitations of the study? This is a retrospective design which carries, its own limits. Most of the hypo and hyperglycemia were self-reported, and they were not systemically validated. The lab measurements of albuminuria and eGFR were not standardized across all the centers. Then clinic-based recruitment might call for some bias in the recruitment. However, this is the first study ever that looked at albuminuria as a risk for fasting. And we definitely need future studies with prospective designs to try to assess this point again. So in conclusion, albuminuria signals early glycemic instability even with normal eGFR, while reduced eGFR marks the highest risk. Pre-Ramadan assessment and tailored education are essential for safer fasting in this group. Ramadan fasting is common in patients with type 2 diabetes with diabetic kidney disease, but poses a significant risk of hypoglycemia and hyperglycemia. Thank you very much for listening.